Okay, kia ora everybody. Welcome to the Rural Women New Zealand webinar, Rural Maternal Health Hauora, in partnership with the College of Midwives. So with us today we have the President of Rural Women New Zealand, Fiona Gower. We have the Chief Executive of the College of Midwives, Alison Eddy. And we have two midwives with us from the South Island. We have Kendra Short from South Canterbury, and we have Morgan Weathington from Wanaka. So the presenters today will talk about the challenges in rural maternal care, but also the solutions so that we can all work together on policy that we can articulate, if that's the term, to decision makers. And what I would like to just quickly go through with you all is that each presentation will be between 5 and 7 minutes, and we'll have the Q&A afterwards. Now we have staff here with us that are watching the Q&A space and will keep an eye on the questions, and it also is attendees and panellists, you are able to actually upvote those questions to become priority ones. So, but we'll take care of those at the end of the presentations. And we also have staff here monitoring the chat, so we can keep an eye, on anybody that has any questions or comments through the chat. If you're having issues with technology, and probably you're not here right now if you are, but if you are on the line and having trouble, give us a bell on 0800 256 467, so we might be able to help you out with that. I have sent an email to the attendees today too, for all of those who are online. The webinar is being recorded and will be shared on the Rural Women New Zealand website shortly after the event, once we get through all those technical bits and pieces that we need to do with it. All the attendees, you have your video and audio turned off, and the panellists and me when I'm speaking, I will be seen by all. Many thanks for registering, and Fiona, the floor is yours.
Okay, thank you, Angela, and kia ora tātou. It's a great pleasure and a privilege to be part of this first webinar for Rural Women New Zealand. Now, I do apologise if I disappear partway through this presentation. Being rural, I'm having a few issues with the internet today. I think it's because of the weather, I'm not quite sure. So hopefully I can hang in there with you. So just a little bit of a background is Rural Women New Zealand have been around since 1925, supporting our women, their families and their communities. We are a very respected voice on a lot of issues, on health, education, social and of course environmental issues as well. And these will affect our rural communities. There is a very strong focus on health and well-being at the moment, and especially maternal health has reared its head in the last little while for sure. It's always been a priority, ensuring that not only our mothers and our babies are being cared for, but also the family, and most importantly, those rural midwives or the midwives that are so important to that care for our mother and child. As a mother of two children that were born in reasonably remote king country, I certainly understand the importance of having that midwife and that relationship with them. And I thank who I had, because that was so important for my well-being and for my family. And I know some of the distances that we had to travel and they had to travel to come and see us was pretty huge. So big ups to everybody for that. So some of the things that we'd like to bring about today is the issues that we can see for our maternal health services and what's been happening in the last little while. We realise that there's been quite an issue with closures from different places, especially in the South Island, and making sure that we have access to services for our women. And what we're really concerned about is the access to services, the access to hospital care, access to midwives, and supporting our midwives to get that care out to our mothers, their children and their families. And we look at the distances that a lot of us either have to travel for those services or for the midwife coming to us, and we realise that it's quite an issue. And travelling for things like ultrasounds and diagnostics can be quite a challenge, and we really like to see those come closer to home if possible to support the work that the midwives do. We certainly have a look at the differences and the challenges around the country for our midwives, and one of the things we look at, and every community has different challenges, and if we look at the South Island, it's things like the distances that they have to travel for either for the mothers or for the midwives to get to the services, to get to the hospitals. And we take into account things like the weather, especially in winter when you've got ice and snow and dodgy road conditions, like that can be a real problem. In the North Island, yes, it is a distance, but also there's quite an issue about other issues around deprivation of our mothers and their families, making sure that they're kept well. So Rural Women New Zealand has always consistently been on the case for maternal health and making sure that it's being the voice for them. And we're really pleased to see that there has been an increase in funding for maternal services, and we're really looking forward to seeing how that fits in with the maternal health services, and especially for our rural midwives. And I'd like to acknowledge the College of Midwives and the midwives that are on here today for the work that you do, because it's incredibly valuable, and all those mothers and children and families out there that use you, and you're not just a midwife, but you become a very valuable source of information and also a source of support and when we need it, and looking after ourselves, looking after our families. So thank you for that. So it's definitely Rural Women New Zealand. We've been doing it for nearly 100 years, advocating for our women, and we'll carry on doing that same thing. And I look forward to hearing from what the issues are from these midwives and how we can move this forward and find solutions for you. So kia ora, and I look forward to hearing from you.
Thank you very much. Thank you very much there, Fiona. Alison.
The mute. Look, kia ora tātou, and thank you Rural Women New Zealand, Fiona, for your introduction and for the invitation to participate today, and also for the advocacy that we know Rural Women New Zealand has been very active in doing over the last few years in particular, but also as you've just pointed out, for your long history of advocating for rural women and rural communities. We really acknowledge and thank you for that, and recognise when we stand together we have a much more powerful voice, and that is very much in the tradition of midwifery in New Zealand, actually walking alongside women, because we really want the same things that you do. We want healthy, thriving mothers in all of our communities, and particularly rural ones where we know there are absolute challenges around access to care. So in the interest of full disclosure, I have to say I'm not a rural midwife. I have worked in remote rural Australia as a midwife, but not in Aotearoa. But I have worked at the college now for nearly 2 decades, and in that role I have had contact with many rural midwives without New Zealand, and also working at a sort of policy system structures level, have really got a good understanding of some of the barriers that have created challenges to the sustainability of rural maternity services. So we have 2 midwives from the South Island who'll be able to obviously share their insights and experiences, but just picking up on your point, Fiona, the challenges are similar but different across our 2 islands, and we hope that in the future we maybe have an opportunity to have a North Island rural midwifery seminar or webinar, which can actually speak to some of the different and unique challenges around the sort of geography and demography of that other island in the north. So I'll just move through I'll share my screen now. I've got a very quick slideshow, which hopefully I can get to come up. Here we go. So just touching on rural midwifery again, rural midwives all midwives are educated in the same scope of practice in New Zealand. It's where they choose to work that defines them and actually makes them a rural midwife. And as you can see in the slide, we have midwives here it's Karina Parata from the East Cape, Claire Eyes, who's a midwife from Pukekohe on the top right, and Bex Tidball, who's a midwife from rural North Canterbury. So we're in all of your communities, not perhaps as many as we'd like to be, but we really cover the breadth of New Zealand, and our education program enables midwives to practice across that full scope. But I think it takes a certain character to choose to be a rural midwife, because there's a lot of skill and a lot of tools that they need in their toolkits. It's not everybody's cup of tea. And what I see is where we home grow our rural midwives. So we grow women who are born and bred rurally, or who are from rural communities, who then choose to become midwives. And fortunately, our education program enables that to occur. We have satellite, our sort of hub and spoke model, so we can grow midwives from rural communities to become midwives within those communities. That's where we often get the best retention and a long-term commitment. Women such as Kendra and Morgan, who are embedded and very much part of their own communities and have a real desire to want to serve those communities, where we know we can get the best out of the service. As you talked about, Fiona, we believe that it's a really key time in a woman and family's life, having a baby, and if we can access if women can access those services closer to home, it actually improves their whole process, their whole experience, because they can also remain close to their family. They can draw the support around them that they need. It's not disruptive. They don't have to be removed from the key supports around the time that they're having their baby, or to access those other services that you highlighted, you know, diagnostic and other services. Huge barriers around geography and cost for that. And, you know, part of our service also requires care in women's homes in the postnatal period. So, you know, there's a lot of time on the road. And we're also, midwives are deeply networked within the wider health service within their community too. They can't do it on their own, but there are unique challenges around the sustainability because of the distances they travel, the populations that they serve, and the requirements on them when they don't have a base hospital on their doorstep or access to those additional services. They have to have, you know, quick response and are often highly skilled. So just touching on maternity facilities, this I was just in preparation for this, just looked through a report that one of my colleagues had prepared in 2011, and the blue dots are all the base hospitals, so the secondary or tertiary hospitals, and the green dots are the primary maternity facilities. So they are midwifery-led services. Often they could be standalone, or they may be co-located with a rural hospital, but they don't have anaesthetics, you know, surgery or obstetricians on site. Really, they're midwifery-led services. So this was the state in 2011. These are the facilities that were in existence. And when I looked at the map and went through which ones had closed since that time, so over 9 years, in the North Island, I counted these ones that are no longer offering primary maternity service. So the facility's closed. There have been a couple of, one additional one built, I think, to replace one of them, but in the main, these services are withdrawn. So that's Dargaville in the far north, Morrinsville in rural Waikato, Murupara in the Bay of Plenty, Stratford in Taranaki, Waipukurau in Bay of Plenty, Napier, which is not a rural facility, but it was a primary facility, Martin and Ratahi, which were in Wanganui, and Tikuiti, again in rural Taranaki. And in the South Island, since over that time, Akaroa used to have a primary maternity facility, no longer available, Darfield and Ellesmere in rural Canterbury, Ranfurly in rural Otago, and Lumsden and Tuatapere in rural Southland. So as you can see, that's a significant loss of service in some of our most remote and, you know, communities where women are really challenged to access care. And I think what we've seen is there's a historic facilities that have, you know, over time the population has moved away from those areas, or the services have been difficult to maintain because the workforce isn't there. And I think that's a really important point that I want the audience to understand, is that there's a really close and symbiotic nature between a rural primary maternity facility and the community midwifery workforce. Without one, there's an imbalance, and without a facility in the proximity of where the midwife is working, it makes her job incredibly hard to sustain. So these things sort of go hand in hand, and what happens is if the service becomes underutilised because the workforce isn't there, and the District Health Board, which funds the service, looks at it and says, well, that's no longer economic for us to continue to provide that service, so it becomes withdrawn. And then you're in this downward spiral because you can't attract midwives to the area because there is no service for them to base themselves out of, and the women in the community suffer. So this is the state of play. It's not as good as we would like it to be, and it's part of the challenges that we have in retaining the workforce. One of the other things that when I was setting up the webinar with Liz and said that the audience would be interested in is how midwives are funded, because as you highlighted, there's been a lot of issues with this, and I'll just run through how the model works just so the audience is really clear, and then talk a little bit more about that. So the midwives are funded through this document. Is called contract. It's the Maternity Services Notice, and it's actually sits within an Act of Parliament, and the funding goes directly from the Ministry of Health to a midwife. So it doesn't go through a DHB like a lot of other funding does. And that funding's based around the woman, the midwife registering a woman for care. And there's a particular amount of funding allocated to the modules of care that the midwife provides based on that individual woman and what services the midwife provides to her. And midwives generally work in small group practices. And in the rural communities, this is challenging because there's less midwives to have as colleagues. But when you're providing a 24/7 service, which is what the notice requires you to do, to be available and on call, and as we know, babies come all day, all night, anytime, it's very hard to sustain that without a collegial support, strong collegial support, so you can have time off and back up when you need it. And this is one of our particular challenges in the rural communities, where there aren't the volume of women necessarily to sustain the midwife financially, because, you know, as we've highlighted, the funding is attached to the individual woman, yet the midwife needs to have, you know, regular time off to attain a work-life balance. So when we break that down a little more, the modules in the notice sit around the pregnancy care, the labour and birth, and the postnatal care, with a little bit additional money for travel, for rural midwives only. And when you look at how that's apportioned across the care, and this is one of the issues we have with our current model of funding, is the apportionment is very much, it doesn't start hitting the midwife's pocket until the woman's completed about 7 months of pregnancy or 28 weeks of pregnancy, even though the care has been provided often from very early in pregnancy. A large apportionment of the money sits within that labour and birth module. So the woman, when she actually gives birth, these are diagrammatically sort of trying to represent how the money is apportioned. So you can see that if the labour and birth fee is missed because the woman needs to travel to the base hospital, she can't give birth locally and the midwife can't travel with her, that makes a significant impact on the midwife's income and means that it creates this financial sustainability challenges for her. So this is an issue that we've been trying to negotiate for some time now with the Ministry of Health, to actually have a better funded service overall, but actually a better funding arrangement, so we don't have all this weighting into this one module for care, which is obviously an important one, but it just means that it makes it incredibly difficult for rural services and rural midwives to maintain financial sustainability, particularly if they're in covering a very large geographic area with a lot of additional costs around that. And missing out on, you know, a big portion of their income for reasons that are beyond their control. It's really unsatisfactory, has been part of the problem of retention and recruitment and retention into rural areas for midwifery. We've made some progress, but we've still got some way to go with that. And this is just my final slide. This is just highlighting some of the costs that rural midwives have that are unique to them, really. And obviously all midwives have to have equipment, and they have, but as a rural midwife, there will be greater needs of equipment that they need to have, simply because they're so far away from other services, equipment that urban midwives wouldn't consider that they'd need to purchase around resuscitation or additional things that midwives need to do because they can't have access to easy referral services around breastfeeding support, for example, that they may in an urban centre. So there's higher costs associated with that. Travel is an enormous cost, the kilometres, and I'm sure Kendra and Morgan can give you some really good examples of that, and needing a good vehicle that you need to maintain. And the communication costs, again, you know, the cell phone reception and difficulties with that, internet connection just make the job much harder. The helicopters there, because transfer is a big issue. When midwives, if they have to transfer to a base hospital from a rural area in a helicopter or a ambulance, then often they can be stuck in the city and have to then find their own way back home. You know, and that can be really expensive. And I'm sure that there's plenty of stories that Kendra and Morgan can share with that. You know, people's husbands having to come and pick them up, having to get a motel in town overnight because you're too tired to drive back yourself, or you really haven't got your car, you have to catch the bus. You know, things like that just make the job that much harder. Obviously, their clinics, you know, they have to pay for clinics rentals, and the ferry is a North Island issue, but the midwives tell us in the Bay of Islands and some places there's, you know, costs with that as well. So I'll stop sharing now so you can see me. But that's just a bit of a quick whip through my take, really. And, you know, talking about solutions, and I know hopefully we'll get more time to talk about that, but I think, you know, I think there's lots of things that we can do together when we put our voices beside each other. And, you know, thank you for your advocacy already. But I also think there is more, I'm sure, that we can do as well, and hopefully we'll get a chance to talk through some of those in the question and answer session. Thank you.
Thank you very much, Alison. Thank you. Kendra, your turn. Just tell us a little bit, yeah.
All right, so good afternoon, kia ora. Thanks for having me. This is a real privilege to share a little bit of my life as a rural midwife with you all. As said, my name is Kendra. I live near Geraldine in South Canterbury, and I serve the community there and also in rural Mackenzie country, so high country as well. Massive area, mountains, lakes, beautiful, awesome, snow, rain, everything else. We have so many challenges as rural midwives that potentially our urban colleagues don't have. Thank goodness we don't really have the traffic that they have though, so we're all good there. But you know, in terms of the challenges of access, there will be a little bit of repetition on what Fiona and Alison have said, but for us, the big ones, those access to services, the network coverage, the travel, the geography and the weather, the worrying when the snow hits about all those women you have due and how they're going to get in, and the one road in and out, and what happens if they go into labour and we're stuck. It's a real honour doing our job. We get to go into women's homes, we get to meet them, their partners, their family, their friends, their sheep, their calves, their everything, dogs, everyone, and we get to see their support. It really came to the fore with COVID. I think it upped the ante for all of us, and made us realise what an honour it was being in there when we were literally the only people going in. Grandma couldn't beat her baby, but I had 6 weeks with that baby, and that was really hard, and we felt quite guilty, but also such an honour to do that. We also became far more, our role was so much wider in COVID, in that we were mental health counsellors, we were lab techs taking blood all the time and couriering that blood into the lab because the women couldn't get in, they weren't allowed out. We were there for a lot longer, in my experience, than we normally were. At 6 weeks, we usually say goodbye, have a cup of tea, and it's lovely to say goodbye and see these women grown into mums. But I was getting calls for an extra 6 weeks after that, because some of the services that would normally be available for those families were not, and they were not face-to-face. Plunket were doing video conferences and things, and that's really awesome. However, our relationships are really hands-on, and lots of these women needed people stepping in, and that ended up being still us. In that, our bubbles were overlapping. We constantly had that worry that we were at risk because we were seeing so many different bubbles, and we had our own lovely bubbles at home with our own families, and I did certainly have some days when I came in, had a shower and didn't see my family because I was worried about what I might have been exposed to. So huge difference, you know, in that time, and thank goodness it's not all the time, but it's something that we really had to think about there. The access for these women to routine services that urban will just take for granted, popping in the car and going down 10 minutes downtown to get a scan. We pop in the car and go 2.5 hours to go and get a scan. And you know, it's for us, it might be a 4 or 5 hour round trip to go and do a 45-minute postnatal appointment with these women in their homes. And you know, an urban midwife might have seen 6 or 7 families in that time, and we've seen one, and we get paid for one appointment, and it's not all about the money, but man, that helps. And our cars, as Alison said, so I travel between 60 and 70,000 kilometres per year in my car, and the local garage always have a bit of a laugh when I ring up and say, you know, oh yeah, it's been 6 weeks, I'm due for a service, thank you. And they didn't believe me the first few times until they actually saw the car. So we need decent cars, decent tyres, decent everything. We've got to pay for those repairs. We've got to be able to have fuel in our cars all the time so we can get out. And we need big, decent 4-wheel drives because we're travelling through snow and fords and farm tracks and everything else, and paddocks and everything else. So, you know, that is a real reality for us as rural midwives. you know, the reverse of it all, of us travelling, is that the women have to travel. So that access for them for those services, even down to things like antenatal education that we take for granted, going along to an antenatal class when you're all excited and it makes the time go fast, that's really difficult for them. We're lucky in South Canterbury, we've got an educator that will take a class to Twizel, you know, 2.5 hours from our door, do a few hours there with groups, but that's twice a year. All right, so we're really lucky with that, and lots of areas don't have that, but that's a real reality. And you know, a lovely solution would be to be able to, you know, take these services to the rural communities, to our communities, even down to mobile ultrasounds and things like that for routine diagnostic things, I think is a really doable solution. And yes, it's going to take money, but actually let's take some of this to our communities rather than all those people in those communities travelling separately for something that's quite routine. The penalty for these women in terms of cost and childcare and everything else to go to these appointments means that many of them don't come. And so we miss things. And that can be really devastating for these families, for these women and these babies, if something's missed because they couldn't make it in there. There wasn't any public transport. Again, COVID did that. Some of the community transport didn't happen. So some of our rural communities were penalised again by not being able to attend appointments because the community car wasn't going in weekly as it normally does. We often, as rural midwives, we have a lower caseload, and Alison has chatted about the funding there. Purely through travel and time needed, we have to have, and population, we have a lower caseload, and that means that we don't get the same payments as urban midwives, you know, on a yearly basis. So that becomes really hard to attract midwives to those areas. The remuneration isn't the same. The amount of time you spend is the same or more, but it's not for the same amount of money. And acknowledging the fact that actually, you know, I would spend the same amount of time caring for 2 women that you know, per month as an urban midwife might spend caring for 6, but she gets 3 times as much because of the way the payment schedule is. The support for families, you know, of families is huge, and we know that this is very, very important and vital to these new babies and these communities, and the women, and when they have to go across to other base hospitals or tertiary level care, they're separated from their families and their communities and their support, and that can be a huge financial penalty for them, and it can be it splits families up. And we know that rural communities are really close, and it really just hurts us when we're split up. We also, you know, we talk about, you know, coming areas and things like that. We need more midwives in rural areas, and thankfully our degree programs, certainly at the 2 South Island institutions, do cater for that, and that we can train in our own areas. But trying to get some extra people to come through to those areas and come and work here, if we can't have the support, the access to services and the funding for that, we're never going to attract new people. The only people we're going to get are the people that already live here, who are wonderful, of course we are, but it is really difficult to recruit to these areas. New grads don't want to come because they know that they have to set up a massive birth kit in their boot. You know, and they have to be able to speak to the helicopter pilot, and they have to be able to have their emergency skills absolutely top notch, as most midwives, of course we have to, but rural, there's just something else. When you've got a woman 2 hours away and she's bleeding and you're organising everything because the paramedics are still 45 minutes away, you've got to do extra things there and be really competent. And yes, then you get in the chopper or the ambulance and you go 2 hours, and then your car's still 2 hours away on the back of some farm somewhere. And yeah, my husband has absolutely come out and found me at the hospital and driven me back to my car, hence more fuel for us. You know, it's really, we love it. Of course we love it. And at the end of the day, we're rural women ourselves, and we absolutely love our job and we love our communities. but we see the inadequacies and the inequities of access for our women. And we just want to be able to get the best outcomes for our rural communities and keep our rural community together. It saddens us when families have to leave because of inadequate access to services. And you know, the lovely research that they've done about rural Scotland and rural New Zealand and saying midwifery is an expensive hobby. Yep, absolutely. It is, but we love it. So thank you. Sorry,
Yeah,
talking.
it's all right. Well done, Kendra. Thank you very much. Morgan, you're 5 to 7 minutes.
Kia ora. Thank you. Thanks for having me, everybody. My name is Morgan Weathington, and I'm a midwife here in Wanaka. And I've moved my family here from Canada in 2012, and I had the pleasure of going through the New Zealand midwifery schooling here and living remote rurally in this region. So, and it never crossed my mind that I would go anywhere else to practice. It's been a pleasure and painful practicing out here at the same time. And I find myself continually trying to improve the services and navigate all the different ways that we can do that. I've got a short, really short slideshow with some pictures that I'll show you, and it's reiterating the same things that Alison and Kendra have said. So I'll just share my screen here. Let's see, should go. So what I wanted to talk today about the importance of rural primary units to rural communities. And the reason I wanted to bring that up today is because Wanaka is 3.5 hours from our closest tertiary hospital. Our closest primary unit is 1 hour away. And we're finding that we have anywhere from a 30 to sometimes 40% home birth rate here in Wanaka. We find not all of it planned. So it's not that unplanned is unsafe. It's just it's the woman's second choice. She wants to get to the primary unit, but by the time that we get to her and assess her, she's 8 centimeters and it's safer to stay in the building than get on the road and have her baby at the Big Fruit, if anybody's been to Cromwell. So it's the dreaded Big Fruit birth that everyone tries to avoid. We have a really high home birth rate, both planned and unplanned. I think the national average, and correct me if I'm wrong, Alison, but I think it's about 10% in New Zealand. 4%.
4%. Yeah.
Oh, wow.
Mm-hmm.
We have a lot of skills around primary birthing. What we would like to see to stabilize our midwifery workforce, which is what you need in order to serve women who are planning to birth rurally, is you need to have enough midwives to attend them. So you don't just need one midwife, you need 2 midwives, and they need to be well and rested. So in the rural setting, just as Alison and Kendra have suggested, that we need to have a midwifery workforce that is large enough to sustain people birthing in the primary communities, which is more than just 1 or 2 people, which is often all the money can sustain, but actually the work needs to sustain 6 to 8 people. And on paper, the primary unit, for those who don't know the lingo, on paper, a primary unit is, as Alison touched on, it's a midwifery-led unit for low-risk birth and immediate postnatal stay. 2 days is funded at the moment, postnatally. And research shows that it provides comparable outcomes for low-risk women, and low risk is categorized as one baby on board, and mom and baby are both well in their pregnancy and medically, and that the pregnancy is more than 37 weeks. And it shows that the outcomes are comparable for low-risk women birthing in a primary unit versus a hospital, but there's less intervention. And transfer rates, when they look at them, are about 10 to 15%, but still, if women start in a primary unit, they have less intervention, it tends to be than if they started in the hospital. What primary units don't do is they don't, as Alison said, they don't provide anesthetics or epidurals, major surgeries such as cesarean sections. We can certainly suture a perineum in a living room or a primary unit if need be, and it doesn't offer secondary care for unwell women. That's my boy right there on the top of treble cone. And So on paper, I gave you a definition of what primary units are on paper, but certainly what primary units are in our hearts in these rural communities is something else altogether. So for the women, it offers a place within her community to have her baby and be close to home. And it makes a huge difference for what she does with her childcare for her toddlers. Some of our primary unit in Alexandra, toddlers can stay on squabs in the building if need be. If the childcare is difficult, they can come and visit and go home. It's not that the woman is relocating 3.5, 4 hours away and being apart from all of her supports, just as Kendra and Alison said. And for midwives, primary units offer collegiality, I think. And when we look at papers that are discussing sustainability of midwifery forces and what sustains a midwife to continue through with their practice, it's the support that she gets from the women, the families, her community, and her colleagues. And when we're so spread out in the rural settings, we don't interface with our colleagues very often. They might come and attend second at a home birth. You might see them at an education day. But if there's a hub that we can work out of, a primary unit that we can work out of where antenatal visits can happen, you see people when there's births that are happening at the same time, or when you're doing postnatal visits, when you interact with your colleagues more often, it feels more collegial, and you feel like you have a place that you fit within, and it doesn't feel so isolating. And I think that that's quite key for midwives. And when we see something like the Lumsden primary unit shutting down, the midwifery force factions, and we see midwives who are now an hour and a half away caring for women, where before there was a whole team of midwives that were in the region and working together and caring for that community. So what we're hoping to do here in Wanaka is to get a building that we can call our own in terms of, and have a primary unit where it will encourage midwives to come and to stay and to interact with each other. And then that will serve, as well as the benefit for the women to be able to have a place that they can birth as their first choice. And I've lost my, maybe, here we go. And I was thinking about how Rural Women of New Zealand can support primary units staying open, or new primary units being opened up. We've done a lot of work in the Southern DHB around where the best maternity unit can sit within Central Otago, and there's talk about moving and relocating or perhaps building another. There is, I just checked in with the woman running that project. That project, the feedback for that project shut on the 22nd of August, but she said that if rural women would like to email in, she's happy for them to email in at this address here, maternity@southerndhb.govt, if they wanted to still make a submission on where and how many units would be appropriate in this region. There's some background there with that website right above. The first point there is the background to that project. We're hoping to hear back from the Southern DHB in October about where primary units are going to be, and we're really pushing for something bigger, because currently the primary units are only funded for birth and postnatal stay, but I believe that they could be more sustainable if the service specification from the Ministry of Health is funded for something broader, all the way from sexual health clinics prior to pregnancy to extended postnatal stays for women who live in extremely remote communities that it's difficult to get to them postnatally as your LMC midwife, to feeder and growers programs, to people having breastfeeding problems, and we could extend it. And if we could get a larger funding for these primary units, they'll be more sustainable. And so I do think we could also write to the Ministry of Health. Let's go for Julianne Genter. Why don't we start there? And then and try and get that service specification widened so that these primary units can be more sustainable. I put Julianne Genter's email down there at the bottom. Okay, so that's me. Thank you.
Thank you very much. Okay, so now the floor is open to participants and attendees. I don't see any questions in the Q&A, but there are some comments in the chat, and if I could just pick up one of those. Liz Pennington's interested to hear the top 3 things that would make a difference in supporting you in your roles. I mean, I know you touched on this, Morgan, but Kendra, if we come back to you, have you got the top 3 things, apart from having a decent car? Well, you'd think Ford would sponsor, wouldn't you? Hey.
Oh, it'd be lovely to be sponsored in my car, absolutely. I actually have an electric car, So yep. So no, it's pretty cool actually. Yeah. So but very expensive too on the outlay, but saving on the fuel. But no, top 3 things. I think being able to take some of those routine diagnostic things to the communities rather than the communities coming into town all the time. These women are travelling for a routine 10-minute consultation, you know, and that's daft. I think that's really daft. Secondly, I think that more working together, out of necessity, we have to work together with our GPs and things like that, of course. However, I think more collegiality there and shared resources so that we can be using the same things. Clinic rooms in rural GP practices, that would be ideal to be able to get those rural women to come and see us at those rooms. And you know, and all of us on the same page, we're all looking after the same people. You know, if we can have some of those sort of things. And I have to say, in terms of some of what, you know, rural women can do and things like that, we know that rural communities support each other. But, you know, just remembering that actually lots of these rural families, especially if they haven't been living in rural areas all their lives, they haven't got the family connections. And so some of it there where we want, you know, you to just go and have a look out for them and that community spirit and things. And some of the things, there's so much expertise with all of you there. You know, you could be doing some of these coffee groups and postnatal stuff, and we're quite happy to come and talk at these sort of things. And just that community support, I suppose, to stop the isolation, you know, of us, but also the isolation of those women and those families, particularly if they're having to move away a little bit for access of care.
Thanks, Kendra. And Morgan, there's a particular question for you, but also if you wanted to pick up some, you know, do you have a different 3 things? But also there's a question there from Jill Naylor asking if you could expand on that wider scope for primary units. Just for a couple of minutes, if you've got.
Sure. So currently, and Alison can correct me if I've got that's a little bit wrong, but currently primary units are funded for birth and for 2 days postnatal stay. If a woman needs longer stays, or if a woman wants to go in and say use a pool to turn her baby to get into a better position before she goes into labor, or go in for or if she's having breastfeeding problems and might need to come in again a week later, that's not funded and goes and just becomes part of the cost that the primary unit has to eat. And so if there is funding for expanded services, the unit would be used more, in which case I believe that it would make the units more sustainable. I also think it could be a place that midwives could work out of, that in terms of antenatal care, so that everybody's working together and interacting with each other and seeing the unit, which I think makes a big difference. When Queenstown Lakes works like this, where the midwives run their antenatal clinics out of the primary unit. Women get used to being in the primary unit, they get comfortable with it, and they find that women then choose to birth locally as opposed to relocating because they're comfortable with the space and they see it. So I think, but there isn't funding for that. Again, that's coming out of the primary unit's pocket, which only funded for birth and for postnatal stay. And so I think if we expanded the specifications of what it could be funded for, means that there's so many more things that we could use it for.
Magic. And so I have been making notes here, lots. Anyway, the second thing is there's a question here, and I'm sure that Alison will be able to answer this. Is there a directory of rural midwives so we can connect? So the members and other, you know, attendees, Rural Women New Zealand members of you know, midwives, I guess.
No, in short, there isn't a specific one, but there is a website called findyourmidwife.co.nz that is linked to our membership database, and it's searchable by region, and you can put filters into that. So you can drill it down to the smaller localities, and it will come up with the contact details and availability of midwives, because that was one of the points that I'd picked up too around how you know, what are some of the solutions. And I think it's knowing where your rural midwives are, knowing where your workforce is, knowing who the midwives are and where they're working is a really important action that rural communities can take, because we're not as visible as other health services because of the nature of the work. I mean, I'm not sure where your clinics, Kendra and Morgan, are, but often rural midwives might have 2 or 3 smaller clinics that they rent off other services, where they may or may not have signage. They may or may not be as visible as rural general practices, for example, may or may not be co-located, and price becomes an issue because sometimes the rent's unaffordable. And I know in Wanaka, very high cost of real estate there, and it's just simply unaffordable sometimes. So that, and because they're mobile as well, they the need to have your time sitting in a clinic is quite different for any midwife, particularly a rural midwife who's got all those travel expectations. So you're not Monday to Friday 9 to 5 in your rooms. You might be there 2 mornings a week, and the rest of the time you're on the road. Quite different to other health services that are often clinic-based, so they've got much more visibility in a community. So there's a sort of a flying under the radar that happens. Doesn't mean the midwives aren't there and not networked and integrated in a very much relationship-based way with other healthcare providers, but they're not often as apparent, and sometimes that can create barriers to women accessing services, but also means that we're just simply a little bit less visible than other services. Yeah, so that is a good starting point. But also we have a national and regional structure as a college, and I'll put our website address in there too, and all of our regional chair people have got their contact details on there. So if you're in the Waikato, for example, and you want to know where to get hold of rural midwives in Te Kuiti or Tokoroa, then our regional chair people can help connect you up as well. So I'll put that address in too. Yeah, and I also want to pick up on Morgan's point as well around the scope of activity in primary maternity units, because the way that our health system works is it's very much sort of activity based and how things are purchased, and that you're right, it's just counting the labour and birth and the postnatal stay when there's an awful lot of other things that are already happening that are not necessarily counted or accounted for or funded out of primary units, and there could be a lot more activity that we could count and add in, but it's the intangible things as well that are not valued, and that includes that collegial support and making the midwife's role much more sustainable by having that network of collegiality around her. And that is that's the missing bit that is not valued or counted by the funders, and then it leads to that demise of the workforce when you don't have those supports in place adequately.
Magic. And Fiona, is there anything you would like to add about the support networks?
I think this is a great idea that if we can connect our rural New Zealand members around the country with our regional teams, with the midwives regional teams, and connect them, support our women that are out there, our midwives, so that they've got that collegial support, that they've got somebody to turn to if they need the ride home, or just need some food because they've been with a woman for a long time, and here's some dinner just to get you through because you're too exhausted to cook or to do, and that's part of the work that we do as well. But it's also being that backstop to help connect with the mothers that might need support, as you say, that a lot of us have shifted to areas where we don't have family or friends, and having that support from members, rural New Zealand members or something like that, just to be like what we call the aunties, to support those women when they need, if they've got issues with, with feeding, or with a young child, if they've got to go stay longer in hospital. Often we can be the aunties and help look after the other family members that are still at home. And having been through the process, and the issues with a woman having cesareans, making sure that they've got support in the home if their partners have to go back to work because they can't do the lifting, especially if they've got another young child. That's where people like women like rural New Zealand can come in really, really handy, because we've got that practical support, we've got that knowledge, and be more than happy to help where we can. So there's a lot of ways I think we can work together on this, and I think what the rural midwives do, and we've heard so much about the fact that they don't get paid the same as their urban counterparts because they've got that longer distance to travel, they've got less cases, and I think that they work twice as hard to get through to that funding. So I think we really need to get behind them and make sure that they get that extra funding and get places like Wanaka up and running again. I like the idea of those primary birthing units so that we can do it all in one place, and having the ideas of the mobile units going around doing the the scans and the tests and all that sort of thing, so that our women aren't having to travel quite so far, meaning they'll do it more likely to have the tests, is really important. So thank you for everything that you do as midwives, from a mother, and we look forward to working with you to make it even better and looking at some of the solutions that you've come up with, which are really, really great, and how we can make them work and how we can push those for you. So Kapai, thank you for all your time today.
Cool, thanks, Fiona. Hey, look, we've just got somebody has come up with a solution that she'd in the Q&A. I'm not sure as panellists if you can see that. Vanda Perish, she's a midwife in Whirianga, Coromandel, and has a fantastic shared facility there that could be a good model to Korowai, Hauora or Hauraki. So they're based Thames and Te Araha, and we also have a visiting obstetrician. So that's a good idea. Comes from Waikato to Thames to see women rather than them travel that 3.5 hours, as you were saying, Kendra, earlier, you know, that sometimes taking the services to rural communities work. So that's great. Thanks for that, Vanda. We also have a question around the workforce of midwives. What is the average age of a midwife? And are there new ones coming through? I think it was you, Kendra, maybe Morgan, touching on, you know, the training and you know, wanting rural women to become midwives or people in your area. But what is the average age? I mean, that's an interesting question, actually.
I think it's about 46, 47, 46, wow. And it's been that age for years, or similar. I think maybe we've got slightly younger, but you know, we've got we do have midwives coming through, and the average age of graduates is gradually getting younger. Historically, it's been around 36, I think, you know, because we've had women that have often had another career or you know, have had children, then wanted to become midwives, and that is gradually getting younger. We're slowly attracting more, you know, sort of a handful of school leavers, but women in their 20s coming through the program, which is good, as long as we can retain them. And that's the challenge, because it's really expensive and challenging to complete the program. We don't have always the best retention. It's a 4-year degree that's been provided historically over 3 years, although the schools are now moving to a 4-year model, because that's been a challenge, you know, to keep them in the program, because it's a really compressed academic year and the workload and all the other commitments that, you know, women have in their lives. But financially, it's really hard too, because it's really difficult to have part-time work when you've got on-call commitments as part of your clinical requirements. That has meant there have been enormous financial barriers as well, and we know we've got disproportionality between the ethnic makeup of the workforce and our population of women seeking care, particularly in the North Island. You know, much more Māori women, Pacific women wanting maternity care than we have midwives from those ethnicities. So there's been a really strong push for us to work hard to grow those workforces, but they have other barriers for themselves to complete the programs too, because of their expectations of their communities on them too, making it even harder. So there's been a lot of work happening nationally to try and sort of address this strategically, but it's just like watching paint dry, watching it filter through the cracks to actually see something tangible actually coming out and making a difference. So I think rural communities have a really big part to play, and Rural Women has a big part to play to support women that you might know in your communities that are going through these programs with other supports, childcare, you know, things that can really make a difference to help them actually being able to get through the program. And I know Morgan's involved with Otago Polytechnic from the Central Otago program, which is run out of Otago Polytechnic. So you might have some other suggestions, Morgan, or ideas or thoughts around that too.
Yeah, Morgan or Kendra? Yep.
It's interesting when you're thinking about younger women, so school leavers or younger women. It's interesting when I look around at who are the people that are in our rural area who are working towards becoming midwives. They're older, and I think if the younger women coming out of the rural communities probably want to go to the city for a bit, check it out, and then they might not come back. Whereas if you can if you can train the if you can build the workforce of the people who are established in their families, I think that works quite well, and that they are going to stay. But that's not everybody. Yeah, I've just started at the Polytechnic, so I'm just getting my feet wet with that. But it's been interesting to see who are the people who are starting the program and who are the people who are finishing the program. There's it's a difficult course.
Mm, mm. Kendra, did you have any thoughts to share?
I think just knowing some of the students that I've had through on placements with me, Morgan's just hit the nail on the head. Really, the young ones, for whatever, you know, they want to go out and they don't want the life of a rural midwife, because, you know, frankly, our time off is pretty poor. And that's our own fault. We know that we just like to get the job done, and we love what we do. But then also we haven't got the workforce to enable that time off, that regular time off. We can't have every weekend off. We can't tell a woman, nah, you can't birth after 5 o'clock in the evening. So the students that come through, if they're rural and they're based rurally, I often find that it's the ones that already have family here, and partner might have a farm or in a service industry or whatever, and they have children at the local school or whatever, and they're going to work here. The ones that come from the city to do their placement think it's a great laugh, and it's amazing that you can have lunch beside the lake and up a mountain and go and have a pie at the Fairly Bake House or whatever you do, and they just think it's a bit of a novelty, and then they go back to the city and you know, and work in the hospitals, because it's, you know, and that's really good. It's a set time that they're working rather than the on-call. The on-call for a rural midwife, I think, is just that little bit extra. We like to think we're special.
I would think you were. Fiona, there's a question for you, and I think this will be our last one, but it's probably actually a really good one to finish on. What was the best part about being supported by a midwife when you had your children in rural New Zealand?
I think it's the fact that being out in the remote King Country, that was being on our own, and having that somebody coming out to visit us, so I didn't have to drive down, especially after having a Caesar, was like going, they came to visit us, they made sure that everything was all right in the house, that my child was okay, and I knew that I could bring them at any time going, help, what do I do now? And, you know, they were going that extra mile, and literally the extra mile to come out to where we were. I think it was about 150 kilometre round trip to come out, and we really appreciate the fact that we could call at any time of the day or night and say, look, I've got a problem, or can I see you? And more than happy to, and they understand how we lived, and introduced us to very much to the local, the other women around the district that had young children, and connected us together, antenatal, postnatal, so that we did have that support group. And even after the 6 weeks of care, they were still there if we needed them, because they really understood that not having that family in the district was really important to connect. And I think it was just that knowledge of care and the level of care, and going the extra distance to make sure, because we did have to travel 2 hours up to the hospital, that they were there with the whole step, and knowing that it was at their cost was incredible. And I couldn't rate the service that we got high enough, because I knew how much they were going out of their way to make it work for us and make our family stay safe and stay well. So thank you to them all.
Thank you. And I just would like to say, on behalf of Rural Women New Zealand and the President and the Board, Fiona, thank you very much for giving your time today to share with us, Morgan and Kendra, knowing that you're busy, and making it safe for our women and children in rural New Zealand. And thank you very much. And to all of you who are watching, thank you for joining us for our first ever webinar. And our summit series has begun with, you know, the start of life. So thank you very much, and we will let you all know when this webinar is available on our website. So thank you very much. Kia ora tātou. Have a good day. Haere rā.
Thank you, Angela. Great job.
Thank you.